Hello, my name is Nicholas Reisner, and I'm going to be discussing the factors associated with county-level SARS-CoV-2 testing volume in 9 U.S. states. Rigorous SARS-CoV-2 testing is an important public health measure, and rigorous testing is important as it allows for early identifications, which facilitate the prevention of transmission and the optimization of resource allocation. Reports suggest that there's a disproportionate burden of illness falling on U.S. racial and ethnic minorities. Yet, little is known about the disparities in the testing rate by race and ethnicity, as well as region and income. This raises the question, are there discrepancies in SARS-CoV-2 testing rates as a function of these factors? Our data is a combination of two things. First, it's county-level testing data, which were sourced from state public health department websites that made the data publicly available. And as of June 7th, 9 of the 50 states did so, which tallied up to a total of 646 counties. Those 9 states were Alabama, Arizona, Delaware, Florida, Indiana, Nevada, Oregon, Tennessee, and Texas. In addition to these county-level testing data, there is county-level sociodemographic data sourced from the U.S. Census Bureau. The outcome we are investigating is county-level SARS-CoV-2 testing rates per 1,000 individuals. And we hope to investigate this using a multivariable Poisson regression model. The results that we found were that there's a median total tests per 1,000 individuals in a county of 30.4. And there's a median total deaths per 10,000 residents of a county of 0.26. Our regression analysis reveals that the state of origin of a county is significantly associated with the testing rate of that county. In addition, we found that Tennessee had the highest rate ratio, and we found so in a preliminary analysis. We then reran the analysis, normalizing the rate ratios to Tennessee. We found that there is substantial interstate variability, ranging from the most testing belonging to Tennessee and the least to Texas, who tested 66% less than Tennessee. In addition, we found that the county mortality rate is significantly associated with testing. It has a rate ratio of 1.04 per death per 10,000. In addition, we found that the average income is not significantly associated with the testing rate. And we found that the racial and ethnic factors are significantly associated with the testing rate, although their magnitude of effect is relatively small. Nonetheless, we found that per 10% increase in the Black/African American population fraction in a given county, the rate ratio is 0.96, which is the relative most. And per 10% increase in the Hispanic population fraction in a given county, there was a rate ratio of 0.85, which was the relative least. In summary, we found that there is statistically significant and substantial between-state differences in SARS-CoV-2 testing rates. We found that the most testing is associated with the Black/African American population fraction, although there was a small effect. And we found that the least testing was associated with the Hispanic population fraction, again with a small effect. We also found that there's no association with the average income. We also considered several limitations. One of these limitations that we've considered is that our analysis was restricted to the states that publicly posted their county level data as of June 7th, which therefore may introduce bias. As well, the results we have reviewed today did not consider covariation of the investigative predictors. Ultimately, we believe that the findings we've shared today should facilitate further investigations into the reasons for the observed discrepancies. Thank you.